So I'll start again. So we were discussing about the role of robotics and endometriosis actually. Now, as I said, the surgeon is more important rather than the machine. So if you look at the what you are going to do is more important, and your skills are more important than anything else. Now, it is basically the surgical strategies rather than the robotic strategies. When do we decide the strategy? Just before the surgery, during the surgery? I would say none of the above, because the surgical strategy is decided before the surgery with the patient in their OPD. Once you have diagnosed the patient properly and you know where all the disease is, a good imaging helps you guide the further plan of action. So when do we treat endometriosis patients? We treat them for pain, we treat them from improving fertility, and we treat when the severe disease is impacting several organ functions. It can be a subocclusive disease or occlusive bowel disease impacting the ureter, hydroureter nephrosis, or in cases of suspected malignancy. Now, to minimize the adverse effects on the ovarian reserve, surgical treatment should be performed by a gynecologist with a specific expertise in endometriosis and fertility enhancing surgeries. In cases of young females who are not yet planning to become pregnant, it would be appropriate to offer fertility preservation such as oocyte freezing and embryo and ovarian tissue cryopreservation before surgery. Anatomy. So whenever you are planning to do complex surgeries, if you are good at anatomy, any surgery becomes easier. Preoperative mapping of the disease is very important. Location and dissection of pelvic spaces, identification of pelvic nerves, isolation of endometriotic nodule, and excision of endometriotic nodule. These are the key principles which are very important when we take patients with deep infiltrating endometriosis. Consent before the surgery from the patient is very important, because when we deal with bowel endometriosis, bladder and ureteric endometriosis, there can be some complications which can increase a lot of morbidity. So a proper counseling for multidisciplinary management of endometriosis is very important, because any patient whom we take for bowel surgery, we should always discuss about what are the symptoms, what is low anterior dissection syndrome, what is the leak rate of the surgery. We should discuss everything with them. Lavanya, are you there?
Yes, doctor, I'm there.
You guys can hear me, right?
Yes, we can hear you, doctor.
Now, this is a preoperative mapping, which I have shown you. We always do it as a NGN mapping, where we look at the peritoneal, ovarian, tubal component, the rectovaginal area, the uterosacral nodules, rectum, and the distant locations. Now, this was the study we published as well, where we did the preoperative mapping and structured reporting of endometriotic lesions on ultrasound, and we correlated on laparoscopy. So ultrasound is a very good tool if done by an experienced and a trained person who can look for deep endometriosis. Pelvic spaces, there are 4 midline spaces and 4 lateral spaces. The midline spaces are retropubic, vesicovaginal, rectovaginal, and retrorectal spaces, 2 paravesical spaces and 2 pararectal spaces. If you have knowledge of these avascular spaces, it is very easy to dissect the planes, because as I said, they are avascular. So once you reach these planes, separating the organs becomes so easy that you can proceed with your surgery successfully. Now, this is, if you look at this screen, this is NGN-U and NGN-S. This is such a common language of communication between a sonologist and the surgeon that if I read this, I'll understand where the disease is. I understand the complexity of the disease. I understand the complexity of my surgery. Now, if it says O2, that means the left side ovarian cyst is between 3 to 7 centimeters. T3 means it is involving the tube which is attached to the ovaries and the uterosacrals and the posterior surface of uterus as well. A3 means the space between the rectum and the vagina is obliterated. B2/2 means uterosacral nodules may be there. C2 means there may be a rectal nodule. FA means there can be a focal adenomyosis of outer myometrium. Now, as I said earlier, that the dissection should start from mobilization of the sigmoid colon and then looking for the all these spaces by identifying the ureter. So ureter is a very important landmark. This is the ureter. Ureter divides the pararectal spaces into two spaces, the medial pararectal and the lateral pararectal. The medial pararectal space is also called as the Okabayashi space, and the lateral pararectal space is called as the Lascaux space. Similarly, pelvic nerves. Pelvic nerves are very important. Pelvic nerves, the most important nerve in this area is the hypogastric plexus. Now, hypogastric nerve identification and sparing of nerve is important because if we damage the hypogastric nerve, patients will have retention of urine, urinary bladder symptoms, and also the symptoms related to bowels. Some patients also have some symptoms because of the irritation of the hypogastric plexus as well. So sparing this nerve during these surgeries, when we do colorectal resections and anastomosis, it is very important that we take care of this nerve so that we do not increase the post-operative morbidity for the patient. Even though nerve-sparing excision of endometriosis is feasible and offers good outcomes in terms of bladder morbidity, digestive and sexual functions seem to be more complex to assess. Excisional techniques used for deep infiltrating endometriosis can result in inadvertent damage to autonomic nervous system, leading to urinary, anorectal, and sexual dysfunction due to lack of anatomical theoretical basis for surgery and inappropriate practical skills. Now, this was the video which I was showing, and unfortunately you could not see. So now I'll be explaining it again. This is a robotic surgery for a patient presenting to us with dysmenorrhea with a visual analog scale of around 8/10 and with chronic pelvic pain and primary infertility. The first step is sigmoid mobilization, and then you can go for uterine suspension and ovarian suspension as well. So uterine suspension using the Keith needle helps us to bring out the disease in the deeper pelvis very easily. Now, these are the endometriomas. Whenever we deal with endometriomas, counseling regarding the reduction in AMH is very important. Counseling regarding the recurrence and the complications is very important. Now, whenever we excise the endometrioma, there may be a reduction in the number of oocytes, or the AMH reduction can be observed initially. But many studies have shown that AMH levels start rising again after 6 to 9 months. Now, similarly, I have suspended the ovaries. So this makes me easily tackle the disease in the posterior compartment. So ovarian suspension and the uterine suspension helps me tackle the disease successfully in the posterior compartment. Now, these are the uterosacral nodules which we are excising. Now, the advantages of robotic surgery are that the camera is in the surgeon's control, and going to deeper areas, or also when the nodule is extending up to the vagina, it is very, very easy to reach and excise the nodule completely. Now, completeness of the excision of nodule can also be checked when a surgeon checks it vaginally. We can feel for the uterosacral nodules if any tissue is remaining, and we can excise it further. Now, here what we are doing is a rectal nodule excision. Now, you can see there is a nodule which we are shaving it off, followed by which we will do a technique of discoid excision using a stapler. Now, this is the nodule which we have excised from the rectum. Then the proline suture is taken, and we try to take the proximal and the distal end of the nodule, and this will be taken inside the circular stapler of size 32, where this abnormal area or the residual area of the disease will be cut through the stapler, and automatically the suturing of the bowel will happen. So with the help of the stapler. This is called as a discoid technique of excision of endometriotic nodule on the rectum. And then we check it with the Ehrlich test. So this is how excision surgery should be done. The completeness of surgery is very, very important.